that this is called contrast and not dye. Okay, a contrast is something that changes the radiopacity of vessels. It makes something called radio-opaque. Now, if you go back to radiation physics, radio-opaque means it does what? If something's radio-opaque, what does it do?
Turns it into white.
Well, it does. What does it do, though? How does it do that? If something's radio-opaque, what does it do?
It absorbs the
That's
light.
how
It
big that
absorbs X-ray. That's right. So when something is radio-opaque, that means it absorbs X-ray. And what we're trying to do with contrast, we're trying to take something that has very low radio opacity, soft tissues, and give them a higher radio opacity so that they will absorb more X-rays than they should. We want to create a contrast. Now remember, contrast is the difference. No, Amber alert. Okay. Radio opacity, everyone's gonna go off here in a second. So radio opacity is the contrast, is the ability to, contrast is the ability to differentiate from one object to another. It is a difference in density. We can have high or low contrast. The more contrast you have, the bigger the difference between the blackness and whiteness on the screen, the different colored grays that we have. So when we're giving a contrast agent, we're making it darker. We're absorbing more X-rays. We're increasing its gray level in the body. So that's what we're attempting to do. It is not a dye. And the reason why we should not use the word dye, other than the fact that we are very superstitious in the cath lab, the term dye means to impart color. Okay? So the term dye means to impart color. That's kind of like a tattoo, things like that. That is what a dye is. It imparts color to tissue, changes the color of tissue. Contrast has no color. It is clear. It does not impart color to the tissues itself. So it's not a dye. Although you will hear people refer to it sometimes to the patient as a dye because it's easier for them to understand. But it's an improper use of the term. This is not a dye. This is a contrast. It has no color. It's not imparting any color. What it's doing is it's absorbing X-rays in a way that the tissue normally cannot. Okay. Contrast agents have a high density agent. Okay. So when we talk about contrast agents, we're talking about the type of contrast. A contrast agent is a substance that produces contrast. And contrast agents have a high density agent, which means there's something inside of them of increased density that will absorb X-rays. Remember, X-rays are absorbed based upon the density of the atom it interacts with. The lower density atoms, it's going to blast through. It might Compton scatter, but it's not going to be totally absorbed. High density objects or high density atoms will cause photoabsorption. Okay? So remember, photoabsorption is what we want to have happen to create the image that we see on our screen. So contrast agents have some sort of high density agent inside of them that performs this procedure. So when we're talking about vascular contrast agents, we use iodine. In specific, we use organic iodine. There's two types of iodine that we can create, organic and inorganic. Inorganics are kind of salts, things like that, that can be created. Those are they're not very conducive to use in our bodies. They create a lot of problems in the body. Our body can utilize organic iodine. Inorganic iodine causes severe problems, causes a lot of issues. Now, before we used organic iodine, we used to use poppy seed oil. Way back in the day when they started to inject vasculature to have it light up, they used poppy seed oil. It was okay, it worked, it had some problems to it, but it proved that we could inject things into vessels and see them under X-ray. Because before I step on the pedal, before we inject the contrast, as you've seen in the lab, before I inject the contrast, can you see the coronary arteries at all?
No.
You can't see any artery. You can kind of see the outline of the heart. You can kind of see the shadow of the heart moving. That's because the heart is a dense muscle. But you can't even see it very clearly. So we have to inject something that goes through the vessels that can absorb X-rays that allows us to see it. And that's why we utilize the contrast agent, the contrast compound. Now we did try to use denser materials. Iodine is okay. There are chemicals that can be utilized in the body that give us even better images. For example, when you have a stomach issue, they will have you drink barium, and it's called a barium swallow. You can drink barium, and they can actually watch you swallow under X-ray, and they can watch that barium bolus go all the way through your intestine and your stomach. They can watch it move. Now, the problem with barium is it's a heavy metal. And it turns out that if you inject a heavy metal into the artery, the patient goes into anaphylactic shock. So that's bad. So we can't use that. So we tried and tried and tried, and most of the things that we tried on animal studies killed the animal. And we're like, well, this is not going well. Poppy seed oil turns out to be effective, but it still didn't give us a great image. And by just trial and error, we came across the use of organic iodine solution sustained in kind of a saline mixture. And that's what we still use today, is this iodine solution. We haven't found anything that's better, that's less toxic. So the problem is there are a lot of things that are better and can provide better contrast under X-ray, but they're more toxic than iodine. Your body naturally uses iodine. So there are other things that have given us better imaging that were actually man-made, but they are more toxic. So we kind of go back to the drawing board and say, well, we have something that's less toxic. It's not without problems, but can give us a good image. So we use this thing called organic iodine. Okay, so we found that organic iodine works. It's effective. There are several characteristics of iodine contrast that we have to understand. These characteristics are so let's talk about characteristics of contrast agents. There are 4 characteristics that we need to know about. And the first one is iodine concentration. Okay. How much iodine is inside the contrast agent? The more iodine contrast or iodine there is in the contrast agent, the better the image you will get. Iodine is the molecule that absorbs the X-ray. So the contrast agent needs to have a certain amount of iodine concentration in order to be effective. And ideally, it is 320 milligrams per milliliter. Although with modern X-ray machines, we can go as low as 300. It's in parentheses because with modern X-ray, we can, this is still considered the appropriate amount of contrast is at least 320. You can go more than that. But in all of our studies, to get a good image, you want at around 320 milligrams of iodine per milliliter of contrast. Okay? That is the optimal amount to get a good image. Not for the patient, we'll talk about that later, not for the patient, but to get a good image, that is the optimal amount to get the amount of density that we want to see the vessels. So after we make sure that we have enough concentration, the next thing that we need to know about it is its viscosity. How thick is the agent? Contrast is like syrup. It is thick. Contrast is extremely thick. It's like a syrup.
Like molasses?
Yes, like molasses. It is very, very thick. And the colder it is, the thicker it is. Which is why when you look at the power injector downstairs, there's a warmer that's attached to it to warm up the contrast agent. Because the warmer the contrast agent is like warming up maple syrup. It pours easier, it moves easier, it's less viscous. But contrast is very, very viscous. And this is going to create some problems. Every contrast agent we use is significantly more viscous than blood. So the contrast agents are viscous. The third thing.
Does it need to be heated to a certain degree? Is it like body temperature heat?
No, we just want to heat it up. Usually it doesn't have enough time to heat up drastically. We just want it a little bit warmer. There's no ideal. If it gets too warm, it'll burn the patient.
Yeah,
So
I
it
think
has
it's
to be
something under
slightly
body
warm.
temp. Something like that.
The next thing that we have is osmolality. Osmolality, well, what does the term osmolar mean?
Diffusion.
Not diffusion, that's a whole different type of, it's same kind of principle, but it's a different theory.
Movement.
Movement of what?
Low
Contrast
to high.
from in the blood.
No, not contrast. Movement
Molecules.
of what though?
Fluid.
What fluid?
Water.
Water, that's right. Osmolality is the ability to pull water, to force water across. So osmolality is a concern because we have a chemical, literally, that's what a contrast agent is. It's a chemical. It is a fluid that we're injecting into the blood vessel. And what it will do is because there's so much more particles in the contrast. Remember, the contrast has 320 milligrams of iodine per milliliter. There's a lot of solute there. And what will happen is it will pull fluid from the tissue space into the blood vessel. Okay? It will actually pull fluid from the vascular tissue, from the tissues that the blood vessels feed. It will pull fluid from the tissue space into the blood vessel at a higher rate than normal. Remember, when we talk about in physiology, what happens is the amount of fluid that's pushed out comes back in from the capillary. But when you add contrast, the contrast has so many solutes in it that it pulls more water into the vessel than it pushes out when it arrives at the capillary bed.
So it's expanding the lumen of the vessel?
It's going to expand the lumen of the vessel, and it also will increase the circulation volume of the systemic system. That means the heart's going to have to circulate more fluid than it usually does.
And that would give you a false reading of the actual size of the artery we're trying
It's
to look at.
not so much that, because this happens at the capillary level, not at the arterial level.
Okay.
It happens at the capillary level. But it is going to cause the heart to have to circulate more volume, and it's going to be uncomfortable for the patient, and we'll talk about that in a second. It becomes very uncomfortable for the patient. So the osmolality is something to be concerned with. The more osmolar it is, the more uncomfortable it will be for the patient, and possibly the more fluid and volume overload we're giving to the heart.
Is that why we mix it with a lot of saline?
We don't mix it with saline. No, you
Oh,
would
I
fix
thought
it.
that's what the contrast was the...
No, it already is premixed. No, this is the contrast agent as we inject does this. No. And then we have something called ionicity. Okay. Likelihood of the contrast to break down into free radical ions. Okay.
I with a minus sign and sign for ionicity of free radicals.
That is for the free radical ion. It can be plus or minus. Since it is a transitional metal, it can kind of add or lose electrons. In case we're worried about it loses. And so now when iodine is in the bloodstream, the body automatically starts breaking down that iodine. It starts breaking down that contrast agent. And when it breaks down that contrast agent, it creates these free-floating iodine molecules in the blood. And that's going to create a whole sort of issues because free-floating ions like to do what?
Go and attach to something.
Yeah, they want to attach to something else that's free-floating.
Cause room breakage.
Damage.
That's more in the cell. This is in the blood vessels itself. This is going to create other problems that we'll talk about in a second. It's going to start to combine with other free floating ions that are going to become very, very complicated. Or I should say it's going to cause a lot of complications for the patient. So these are the 4 factors of contrast that we have to keep in mind. We want an ample iodine concentration, but as my iodine concentration goes up, the likelihood of my ionicity also goes up. My osmolality, the thickness, well, the more iodine I have, the thicker that contrast will be. Okay? Or viscosity, or osmolality. Osmolality is the likelihood of pulling fluid in. Well, if I have a high iodine concentration, there's a lot of free-flowing particles, and water always goes from low concentration to high concentration of particles, and it's going to pull fluid more. So all of these 4 factors are intertwined with each other. And all 4 of these factors cause us problems. Now the good news is iodine gives us a great contrast. The bad news is these 4 factors of iodine causes our patients severe difficulties and complications that we need to be aware of.
So if there is a higher density as well as higher viscosity, and you have a blockage does that block your contrast at that point?
It can create problems, we'll talk about that in a second. It can make ischemia worse. Okay, so let's talk about some issues that patients have from iodine concentration. So let's talk about complications caused by contrast agents. Bradycardia. What does bradycardia mean?
Slow heart rate.
Slow heart rate. Injecting contrast, especially and more appropriately in the coronary arteries, has a high risk of triggering severe bradycardia. If you do it in other places of the body, not so much. But we're doing this right in the coronary vessels. And so when we do that, there is a risk of bradycardia. Matter of fact, if you remember all the way back to Dr. Soanes. Dr. Soanes, the person who first accidentally injected or subselected a coronary artery for injection. The patient's heart slowed way down, and he yelled at the patient, "Cough!" Okay? And when the patient coughs, coughing acts as a compressive stimulant to the heart, and the heart rate will generally pick up. We still do that today, by the way. There are patients when we inject contrast, their heart rate will slow, and you hear people yell, "Cough!" And when they cough, that percussive stimulant usually will bring their heart rate back to a stable rate without the administration of medications. Usually. Doesn't always work, but usually. So every now and then you'll hear somebody yell, "Cough!" and the patient will cough and the heart rate will come up. It's less and less common for us to need to do that. We'll explain why in a second. But it is still something that's in our repertoire where if something happens to the patient's heart rate, we can yell "cough" and hopefully that will bring it back up to where it needs to be. The question is, why does bradycardia occur? Well, this has to do with ionicity. Iodine likes to bind with calcium. What is calcium used in?
Wrenching
What's that?
that myosin and.
Muscle
It's
stimulation,
used for muscle
contraction.
stimulation and contraction. It's part of the action potential. And so what my iodine will do is it'll start to bind to the calcium around the myocytes. And if the iodine is bound to the calcium around the myocytes no longer have access to that calcium. Remember, the calcium is sitting outside the myocyte, and it rushes in. Well, if the iodine is binding with that calcium before it can rush in, there's less calcium to rush in, and the heart rate will automatically slow down.
Is it like prolonging the plateau
Yep.
period?
It prolongs the plateau period. And as long as I'm in the plateau period, I can't reset, and I can't stimulate again. And so the iodine is binding with all that calcium. That plateau phase takes longer to complete, and the heart rate slows down. So, bradycardia, ionicity, not fun. At the same time, it decreases the contractility. The ionicity decreases the contractility. Makes sense because in order to contract, what ion do I need?
Calcium.
Calcium. So if the iodine is binding with all the calcium, or a lot of the calcium, the heart's contraction is going to decrease. This is really bad for people who are in severe congestive heart failure. Their hearts already cannot contract well, can't deal with the volume overload, and they have issues. So that's why if you read in relative contraindications, you'll notice congestive uncontrolled or untreated congestive heart failure.
What if they're already on like a beta blocker where
It just depends. There's still a risk of this, but we'd be more comfortable doing that patient than a patient who is not being treated. But calcium channel blockers can cause problems and make congestive heart failure worse. Allergic reactions are also associated with ionicity. A lot of people, when they're allergic to contrast, they're allergic to the iodine in the contrast. So if the contrast agent breaks down to a lot of free-floating iodine molecules, the body's going to notice that and trigger an allergic response if you're predisposed to that allergy. And these patients will get hives, they may get short of breath, or they could go complete anaphylaxis. And anaphylaxis means the blood pressure drops, the heart rate skyrockets, the contractility drops, you have edema and fluid buildup in the tissues, and the patient could die. This is attributed to the ionicity, again, of the contrast agent. The more likely it's going to break down to free-floating iodine ions, the more likely the body's going to react to it, and you're going to have these allergic reactions. Before we had the new contrast agents that we have now, we used to do test injections, where at the beginning of the procedure, before we started taking a lot of pictures, we just inject a little bit of contrast into the blood vessels, and to see if there's a reaction. If there is a reaction, we give them Benadryl and get them ready to go. And with the new contrast agents that we have, we don't need that as much anymore. We'll talk about that in a second.
What percentage of people have an anaphylactic or?
Very few, less than 1%.
Can we give them Benadryl?
Yep.
And continue?
If there's ever a question of if a patient's allergic to contrast agents, we will give them Benadryl. We used to believe that shellfish allergy or strawberry allergy were related to contrast allergy. Totally is not. There's no connection.
I remember hearing that for forever.
Yep, there's no connection. None. Zero, zip, zilch, no connection whatsoever between shellfish allergy, strawberry allergy, and contrast. It was a very poorly conceived study. When we've done every study we've done since the 1970s, totally disproves a connection between shellfish, strawberry allergy, and contrast allergy. It doesn't exist. Although people have it so ingrained in their head that we'll still medicate them as if they do have an allergy because the patients get worried. But there is no connection. There's absolutely no connection. But you'll still hear people get medicated with Benadryl because they have a shellfish allergy. Is it necessary? There is no connection. We do that more to cover our butts and to assuage the patient's concerns because they've heard it.
Help them relax too.
Was that? Yeah, they're a lot more relaxed. They're very, very relaxed. Okay. Nausea and vomiting. Nausea and vomiting is associated with both ionicity and osmolality. By the way, nausea and vomiting is not an allergic reaction. You hear people say, I'm allergic to it, it makes me nauseous. That's not an allergic reaction. That's an adverse reaction. An adverse reaction, remember, is a reaction that might happen. It's not uncommon. We don't want it to happen, but it could. Nausea and vomiting is an adverse reaction, not an allergic reaction. But for the ionicity, it's just an irritant to the body, that much of iodine, and the osmolality, that sudden change of fluid, especially if it, as it cycles to your body, because to get to your kidney, the contrast has to cycle through all of your vessels to get to your kidneys. If it that increase in osmolality as it goes past your stomach vessels can pull in more fluid, and it can trigger some nausea and vomiting, nausea feelings and upset stomach feelings, and people can throw up because of it. In the early stages of contrast agents, we used to call it the shoot and puke, where you would inject and the patient would go and throw up.
That quick?
Yeah, it was inject, they'd be throwing up.
Kind of like injecting a Narcan from an OD.
Yeah,
Like they'll
they'll just
Yes.
throw
you
up.
push it too hard.
Yep. Too far, too fast to throw up. But yeah, we used to call it shoot and puke. The patient, and not everybody would do this, but if the patient was sensitive to the osmolar changes, especially around the GI, they would just vomit. With the new contrast agents, doesn't happen nearly as often. Does it occasionally happen? Yes, but not nearly as often. It used to be you would have somebody by the head, so we inject, and the first injection they'd go, and you would have somebody there to.
Whose responsibility is that to clean it
Circulator.
up? Circulator.
Yep. Another fun thing for the circulator to do.
So you inject your vessel, that happen that fast?
Yeah, it happens very quickly. The body reacts to it very, very quickly.
And then my body will react to it.
Yeah, I gotta get rid of
Then we
it.
need a secondary circulator for you.
I need a circulator.
Hot flashes and pain. This is especially noted if you inject in the peripheral vessels. Not so much in the cardiac, not so much during a heart cath, but if you're doing a peripheral procedure and you inject the contrast, they'll feel hot flash or pain. Or when we do something that we'll be talking about coming up here, an LV gram, when we inject a large amount of contrast into the left ventricle and it contracts, where does that contrast go?
To the body.
Everywhere. And as that contrast goes everywhere, you get this warm flash. And sometimes before we do an LV gram, we usually warn the patient, if I could talk today, we usually warn the patient you're going to feel a warm flushing sensation throughout the body, and you might feel like you've accidentally urinated yourself.
It does
You
feel like
really did not. It's just the warmth triggered by the contrast agent. And it's not because the contrast agent is warm. That's not what's going on here. What's going on here is the contrast agent is pulling fluid from the tissue spaces that causes the vessels to dilate, and that dilation is what triggers that warm, hot flash effect.
It's really intense. I've had a lot of back procedures and
Yeah.
X-rays and
Some people have it
It
really
is
intense,
like-
some people not so intense. It just depends.
You have to
Depends
check
how you
yourself,
react to
like, did I just pee
Yep.
myself?
It feels like it.
That last part, it's pulling fluid.
You're pulling fluid from the tissue space into the blood vessels, and when the blood vessels dilate, remember that's how you get rid of heat. And so it feels like you're having this massive hot flash. When you do it down one leg, it's not going to be your whole body. That one leg will have a hot or warm sensation. And the more intense the pull, the more osmolar the contrast is, the more intense the heat and the pain will be. If you have a blockage and that contrast stays in an artery for a long period of time, that heat and that intensity of discomfort increases. So we need to be aware of that, okay? Osmolality can really cause a lot of discomfort for the patient. And again, it can make them feel like they've peed themselves. And oftentimes they'll say, oh, I think and you're like, no, you're probably, they might have, but you're probably okay. It's just that feeling of that, the dilation of those vessels giving you that warm sensation crossing through your body.
And you were saying that they usually feel it during the left.
When you're doing a ventriculogram, which we haven't talked about yet, when you're injecting a lot of contrast into the left ventricle, when it squeezes, that contrast goes throughout your body. And then when you're injecting down a peripheral vessel, you'll feel it. Not so much the heart, because remember the heart doesn't have any nerves, so your heart doesn't feel it. But when that contrast goes to the periphery, then you feel it.
So is there a way to like dilute it or?
No, because if you dilute it, then you're decreasing the opacification. Because if you dilute it, then you're diluting the iodine molecules, which absorbs the X-ray.
So like even if it is painful, you still don't dilute
You can't
it?
dilute it, otherwise you are separating or distancing the iodine, and it won't absorb it won't be as dense to absorb the contrast, or give me the X-ray.
So it'd be like if they had like a DVT and then you injected it in the peripheral, that they would feel that in that
In that leg until it
in
until
that
it moved
spot
up.
where the clot was at?
Yep.
Okay.
Until it moved past the clot. Oops. Okay. Since the contrast is pulling in more fluid, that's more fluid the heart has to circulate. If the heart is already failing to circulate the blood that it has to deal with normally, and you pull more fluid into that vessel, or into the vessels, that means the heart has to now circulate more fluid than it was. Your heart failure is going to possibly increase. Pulmonary edema occurs because the heart isn't functioning adequately to drain the lungs fast enough. Because the blood goes to the veins, the blood goes through the arteries to the lungs. If the ventricle isn't emptying well, that blood in the lungs isn't going to get back into the ventricle as well. And so it starts to build up in the lungs. So if the heart is failing and you already have fluid building up in the lungs, giving contrast will cause the heart to fail more. What's going to happen to the fluid building up in the lungs? It's going to increase, and that's pulmonary embolism, or excuse me, pulmonary edema.
Is that more for like right-sided heart failure or heart failure?
Left side, number one cause of right-sided heart failure is left-sided
Left-sided
heart
heart
failure.
failure.
So again, osmolality.
So just to make sure I'm not getting lost in the weeds here, more osmolality means more water is pulled into the vessel?
Yep,
Okay.
because osmolality is a pulling.
Okay.
And then we have kidney failure.
Is that CIN?
CIN,
Okay.
SIN.
Contrast.
Contrast-induced nephropathy, often referred to as SIN. Okay, CIN. Contrast-induced nephropathy. Nephrotoxicity, it means that this is poisonous to the nephron. We'll talk about what the nephron is here in a second. We don't understand nephrotoxicity. We really do not know the whole cascade of events that causes this. This is why I have you read several things that talk about what could we try to do to alleviate nephrotoxicity. We've tried a lot of different approaches. None of them have worked. None of them have worked really well. Now, what we do know may be occurring. There is a theory that iodine, and it is true, iodine is toxic to nearly all biological substances in high enough amounts. That's why when we get a cut, what do they put, or before they do surgery, what do they use to put on the skin?
Iodine.
Iodine. Now we use chlorhexidine, but iodine works really well. It is very toxic to biological substances that can absorb it. So one theory is the iodine itself is toxic to the nephron at certain levels. And once you hit that certain level, the nephron will start to be injured. That's possible. The studies we have done, we've tried to see, well, can we avoid that? And it doesn't always work by changing the ionicity, but it seems that ionicity has a role to play in it. The other possibility is that there's a hemodynamic change that occurs in the nephron. Hemodynamic means pressures. There's a pressure change that occurs in the nephron because of contrast. And that would be caused by the contrast osmolality. And the real answer probably is a mixture of the two. It's probably a mixture of the two in some way. The iodine being toxic doesn't help. Added to the pressure changes that occur through the kidney when contrast is present doesn't help. Both of those will lead to kidney failure, or what we call contrast-induced nephrotoxicity.
So that was the question, Mike.
Yeah, we don't know. We're not quite sure. And we tried to fix this, and it didn't decrease my nephrotoxicity a lot. We tried to fix this, it didn't decrease my nephrotoxicity a lot. So we're trying to figure out, well, what's really going on here? It's actually, we think, a combination of the two, and we don't have a good solution yet on how to try to avoid this or fix this.
Did it help individually slightly? It just wasn't enough?
Some studies say yes, some studies say no, so that's the problem, is they contradict each other. The studies seem to, you do one study and it says, oh yeah, it's the ionicity, and you do another study and the kind of following the same protocol and it says, no, our study didn't show that. And so the research contradicts itself. So we're not quite sure what's going on, and we may not figure out for a while. But the key is, the less contrast we give, the better. I mean, look at this list.
Oh, no.
The less contrast we can give, the better. Okay. The other object is, let's build a better contrast. Okay. Let's build a better contrast. And we've tried to do that. Now, when we're trying to build a better contrast, we have a couple of goals that we need to meet. We have a couple of things we want to keep in mind. One, decrease the iodine concentration. If you have less iodine, guess what's going to happen to the ions you create? It's going to be less. They're not going to break down into as many ions. The problem is, If I decrease my iodine, what happens to my opacification? What happens to the ability to absorb X-ray?
Decreases.
It decreases. So it's kind of a scale. I can only go so far before I totally miss the purpose of using contrast. Decrease free-flowing iodine ions. Well, this is a problem because you really can't control how the body breaks down iodine. How are you going to decrease that? Because if I could decrease free-flowing iodine, I can have a higher concentration. If I can keep it from breaking down so I don't have a lot of free radicals in my body, I could keep a higher concentration. But how do you do that? The other thing I want to do is I want to decrease the osmolality. I want it to pull in as little extra fluid as possible, but the only way to really do that is to decrease how much iodine is in it, because it's the iodine that causes the osmolality. So I want to decrease the osmolality, but keep the iodine concentration what it normally is. Can anyone see a problem that I'm dealing with here?
Can't do one without
Affecting the other.
A balance.
So the key is, can we ever find a perfect contrast agent? And the answer is right now, no. And there's a fourth thing that we haven't talked about yet because it doesn't really cause a lot of problems except in specific circumstances. Decrease viscosity would be great. But to decrease the viscosity, you would have to get rid of the osmolality, you would have to get rid of how much iodine is in there. Iodine creates the viscosity. Viscosity doesn't cause other problems except for increasing ischemia. You might say, well, how does it increase ischemia? When I inject contrast down an artery, guess what that contrast displaces? Blood. As I'm injecting contrast down an artery, blood is not getting down that artery as long as the contrast is there. If blood is not getting down that artery as long as the contrast is there, what is the heart not getting?
Oxygen.
It's not getting oxygen. And if it's not getting oxygen, what is it going to have? Ischemia. Ischemia is the hypoxia caused by poor circulation. So let's say that Kim comes in already with chest pain and ischemia. I inject contrast down the artery that's causing the ischemia. What's going to happen to Kim's ischemia as long as that contrast is there?
Increase.
It's going to get worse because her heart's already not getting enough oxygen, and then I put contrast in it, which doesn't have oxygen. It's going to get worse. And the thicker that contrast is, how long is it going to stay in that artery? Longer, which will increase the ischemia even more. Okay.
Does it like prevent the binding of oxygen, or does it?
It just displaces the blood.
Smothers it. Okay.
There's no blood. Where there's contrast, there can't be blood.
Oh, okay.
It replaces the blood.
Oh.
Okay.
And then just as I said, if there is a blockage, it's going to still stay there
Yep.
longer.
Until it is absorbed, it will stay there. Until it is broken down and absorbed, it will stay there. So as long as there's contrast there is no blood delivering oxygen, which is going to cause ischemia. Okay, so this is the ideal contrast agent. There is no such thing, but we are getting better. Now, this chart is a list of contrast agents broken down by type. So we have type, we have the contrast agents in that type, and the information over here. So the first type on here was the very original contrast agents that we started with. The ionic high osmolar contrast agent. So what does that does that type tell you? If it says it's ionic, what does that mean?
It has free radical ion.
Yeah, it's going to produce a lot of free radical ions. And high osmolar means what?
Ions will
What's it going to do in the body?
decrease the
Just,
fluid.
a lot of-
It's going to pull a lot of fluid into the blood vessels. So everything we wanted to avoid, guess what this group of contrast agents did?
Causes it.
It did it. We want to avoid creating ions. Guess what these contrast agents did? Created ions. We wanted to avoid pulling water through osmolality. Guess what this contrast agent did? Pulled water through the osmolality. Every time we injected contrast, the patient's heart would slow down. We would say cough. They would cough, probably throw up, and the heart rate would go back up every single time we took a picture. Then we take a picture, cough. Okay, next picture. Take a picture, cough. Okay, next picture. Take the picture, heart rate slows down, cough. Over and over and over again. There were more than this, but these are the three big names: Rhenographin, Hypake, and Angiovist. Also known as diazoate, diatriazoate. That's the generic name for all of these. They have the exact same chemical formula. Different companies created it. And as you can see, the iodine concentration was really high. The iodine concentration was really high. And the osmolality was also very high. I'm just going to show you something here. No, it's not going to pull it up.
I wonder if there's a way to combine the patient's blood with the contrast
No, 'cause you'll
somehow,
dilute it.
then.
You'll dilute it.
And then
You dilute the contrast. Osmolality of blood, by the way, is 275 to 295. So our original agents were only about 10 times more osmolar than the blood was. So we're talking extreme hot flashes. We're talking about with that high ionicity, the high iodine contrast or content, severe bradycardias, and then pretty high viscosity. That viscosity means it's about 8 times more than water, about 4 times more than blood.
And the 275, but that was blood viscosity?
275 to 295 is blood viscosity. Or I'm sorry, osmolality.
Osmolality.
Viscosity of blood is about 3 to 4. It's 3 to 4 times more than water. This is way more than blood. It's only about 2 to 3 times more than the viscosity than the blood, but it is still thicker. And then somebody said, hey, you know what? We have a lot of problems with this. Wouldn't it be great if we could create a contrast agent that we didn't have to tell the person to cough all the time and didn't cause all these problems? Can we do that? And the answer was, we're going to try. So the second group of contrast agents that came out, oh, by the way, we don't use this first category, we do not use for vascular imaging. Now, it's still being produced, and you might say to yourself, why would it be produced? It's not used for vascular imaging anymore, not for coronaries, not for peripheral. It should never be used. There's no good reason. The American Society of Radiology Technologists says that there's no good reason to use ionic high osmolar contrast agents in a patient. No good reason. Why are they still being made? Well, it's the cheapest. And some of our equipment requires us to prep them with contrast so that we can see them in the body. That contrast would never go into the artery, it would stay in our equipment so we could see it. So that contrast agent, the high osmolar ionic contrast agent, is usually used or reserved now for prepping our equipment. This is used for equipment prep. Balloons, drills, things like that that require us to see in the body. We fill up the equipment with a very cheap contrast agent. It's not going to go into the vessel, but allows us to see our equipment. Since it's so cheap, it's the best way to utilize it. Okay. Then somebody said, okay, I can do something here. I can decrease the osmolality a little bit. Can't change the ionicity. We didn't know how to change the ionicity, but we could decrease the osmolality a little bit. How we did that is, it has something to do with the benzo ring. You don't need to know this. This is biochem. There's ways that you can arrange iodine in a benzo ring. And basically what they did is they found a way to create a larger iodine benzo ring so that there's less free-floating iodine in the mixture, decreasing the osmolality. You don't need to know any of that. I'm just telling you that's how it is done. If you're like, did they dilute it? No, they did dilute it. It has the same amount of iodine, it's just bonded differently. And so it changed the osmolality. It didn't have as many free broken molecules in it. It's called iosaplate. Hexabrix is the trade name. Still at that magic 320. Osmolality came way down. It's only about 2 times as osmolar as blood. Remember, blood osmolality is 275 to 295. This is only about 2 times more osmolar than blood. Significant improvement. And the viscosity went down. But the problem is we only solved some of the issues. With Hexabrix, the patient had less hot flashes. They had less nausea. What the patient still was experiencing is slowing of the heart rate and allergic reactions. Let me ask you, which one makes us more nervous? Hot flashes and nausea? Or heart rate and anaphylactic shock? Heart rate and allergies. So we solved one of the problems, but we didn't solve the largest problem. We didn't solve the biggest problem. It's still being made today. We'll talk about the reason why of that later.
We're still asking them to cough at this point.
Yeah, we're still having to ask them to cough. And they'll still have hives if they're allergic to it. So it didn't solve all of our problems. And it didn't solve the problem with nephron toxicity. Okay? Contrast-induced nephrotoxicity was still a problem. But it was better. I mean, let's face it, it is better. Okay? I mean, they're not complaining of hot flashes. They're not throwing up as much. Hey, that's an improvement in my book. But they were still having slow heart rates and allergic reactions. So then we said, okay, what can we do to make it better? Well, we found out a way to take out the ionicity. So we decreased the osmolality by creating a larger benzo ring. And then we discovered in chemistry, through a chemical process, we can actually create a contrast agent that doesn't break down to ions. And you might say to yourself, Self, how can you do that? You can add a chemical called calcium disodium to the contrast agent. And what does iodine love to bond with?
Calcium.
Calcium. So you actually have calcium inside, calcium disodium inside the bag, so that when the iodine breaks down, instead of stealing it from the heart, it bonds with the fluid itself. It's great. Also, since it bonds with calcium disodium so quickly, there's less free-floating iodine for your body to identify as an invading material. So allergic reactions almost disappear. It's very rare now to have somebody react to our contrast agent just because of adding calcium and disodium. By adding calcium disodium, you don't have this free-floating iodine in your body. There's less likelihood that your body's going to say, hey, that iodine looks suspicious. Let's attack it.
Does it raise the heart rate?
Was that? It doesn't do anything to the heart rate. Remember, the iodine slow down the heart rate. By combining with calcium disodium, it won't have any effect on the heart rate.
I
It'll keep.
figured if it wasn't the proper ratio for that particular person.
Because remember, the calcium has to be absorbed into the interstitial space, but since it's combining with the iodine, it will not cross. So it won't be utilized for that. So it decreases the free-floating iodine concentration. So now, are we yelling at people to cough as often? Occasionally it does happen, but very rarely. And allergic reactions, which were caused almost completely due to the free-floating free radical iodine, is almost gone. Matter of fact, somebody who had an allergy in the early 80s to contrast probably will not react to our current contrast. We still ask, and we won't take that chance. We will still pre-medicate the patient with Benadryl. But there are studies out there that say people who were allergic to our previous contrast agents, especially the ionic high osmolar and the ionic low osmolar, people who are allergic to the ionic contrast agents, when we give them the new contrast agents, we don't really see allergic reactions occurring anymore. We're not going to risk it though. I mean, we're still going to, just in case, pre-medicate them. But it is very unlikely. There are 3 companies who create a non-ionic low osmolar contrast agent. They all have a slightly different chemical formula, so they don't share the same generic name. It's iohexol, iopamidol, and iversol. So it is Omnipaque, Isoview, and Optiray. The 2 most commonly used are Omnipaque and Isoview. Matter of fact, in most hospitals, Omnipaque probably is the one that you're going to hear the most. Omnipaque is by far the most common used. Followed by Isoview. Optiray, not so much. Now the problem that we still have here, we've solved a lot of our problems. We've solved a lot. First problem we solved is allergic reactions, slowing of the heart rate, resolved. Hot flashes and nausea have gone way down. However, notice it says low osmolar. What does that not mean? There's still a little bit of osmolality. So there are still people who will get sick from this, and I can almost guarantee that when you had your back x-ray performed, Stephanie, that you had Omnipaque performed. Was it a CT scan?
MRI. I've had CT, MRI.
Okay. MRIs are something else, but CT scan you probably use Omnipaque, and that will cause you to have that feeling. Because it's not gone, it's just decreased. Now, imagine if they would have given you the old stuff.
They always ask me, have you ever had a reaction
Yeah.
before they give it to me though?
Yeah. Oh yeah, we still will. But imagine if they would have given you a high osmolar contrast agent, and that feeling of warm, flush feeling, and the feeling of you urinating yourself would go through the roof. It's not a comfortable feeling.
It is intense.
It's not a comfortable feeling. You kind of feel like you're sweating. You really don't, but you feel like you're sweating. You feel like you've urinated yourself. It's just a weird feeling. And the other problem is if we inject this into a peripheral vessel, and that contrast does not clear that peripheral vessel fast enough, that peripheral vessel will start to feel like it's burning and will feel painful. Not as bad as this stuff would, but it will still have that effect.
That's used in peripheral stuff?
Not anymore, but it was for the longest time because it's much better than the alternative. So the final thing that we did is somebody said, you know what, we can take this a little bit further. We're going to keep the non-ionic, the calcium to sodium, we're going to keep the non-ionic, and we're going to change the benzo ring one more time. We're going to create an even larger benzo ring. Again, you don't need to know what that means, it's just how the iodine are connected, okay? They're going to change it one more time. Look at the osmolality. When they did that, what happened to the osmolality? It's the same osmolality as blood. 275 to 295 is the osmolality of blood. The non-ionic what does isoosmolar mean, by the way?
Same as.
Same as. Iso means equivalent or same as. So the non-ionic isoosmolar contrast agent, which is the newest contrast agent, which has been around for a while, but it's the newest contrast agent, the iodine formula, the iodine connections, were made in such a way that we greatly decrease the osmolality. It's equal to that of blood now. So the good news is, when we inject this into the left ventricle and it goes through the body, what will the patient feel?
Normal.
Yeah, they won't really feel much of anything. If we inject it down the leg and it sits there for a little bit, will it burn?
No.
Will it hurt? No. It's a great chemical agent. But here's the problem. There's always something you give up.
The
That's
viscosity
great,
is
is the
high.
contrast.
The viscosity is super high. It has the highest viscosity of any contrast agent we have ever made, which means using this on a coronary artery that is ischemic probably is not a good idea. So it's a great contrast agent. Except if you have a coronary artery that's ischemic, it might cause issues. Nope, not very much, nope. Warming it up just decreases the viscosity slightly. So, why do we have these? Well, here we told you here, we use these for equipment, right? We don't use this for injecting. This is still used in some places, especially in developing countries because it's really cheap. It gets rid of some of our problems. The majority of the contrast we will use will be in the non-ionic low osmolar contrast agents. Omnipaque or isotube. It's going to be the most common contrast agents. This is used for special occasions. Now, you might ask yourself, why don't we use Visipaque all the time? With the exception of ischemic coronary. This seems like it should be used all the time. Peripheral arteries, you should always use Visipaque. With patients with severe congestive heart failure, you should use Visipaque because it's not going to pull any more fluid in. Diabetics, you should use Visipaque because it's not going to, the vessels are so small, it's not going to overwhelm the vessel with pulling more fluid in. Why don't we use Visipaque all the time?
It's too thick.
Well, but that's only a problem if you have a severe ischemic artery, though, which we won't until we start. But why don't we use it all the time?
It's expensive.
It's very expensive, that's right. It's about 10 times per milliliter of every other contrast agent. It's the most expensive contrast agent out there.
Do you know how much it is?
I can try to find it. Let me see if I can find a comparison here.
$1,000. So Visipaque, so you everything except ischemic coronary. Right?
Yep.
Okay.
Well, we could use it for that.
But the joy was it.
Let's see what the current exchange rate on it is. So Visipaque is about $600 for 500 milliliters. So for half a liter, it's $600. Omnipake prices are I have to figure out how to convert this here. I don't know how to convert that.
Yeah.
So like,
It's
Omnipay
a drop in the
costs-
bucket, really, at that point.
Omnipake costs, about $50. The same amount.
$50 for 500 ml?
Mhm.
Okay.
So the cost is significant.
Yeah, that's like,
Medicare and Medicaid will not pay for VisiPake unless you have
the reason.
an underlying condition.
Yeah, the ischemia.
Nope. Underlying condition is acute MI, not ischemia, it has to be acute MI, diabetic, renal disease, peripheral vascular procedures.
Okay, because you wouldn't give the VisiPake for ischemia anyway.
We could, but it's not the best idea.
No.
But those are the only four things, those are the four things that they do. Congestive heart failure, or with,
So renal failure?
renal failure, congestive heart failure, peripheral procedures, diabetics.
So it is given for commonly for
Yeah, it is the best one for peripherals. Now, I say that, and then Omnipake got sued, or VisiPake got sued. Okay, so, this is how we break it down. Almost everybody's going to get, depending on what the hospital, let me say it this way, depending on what the hospital wants to do and how much money they want to lose. That's the key. There are some hospitals that give everybody VisiPake. However, the hospital is eating all of the money that Medicare and Medicaid will not cover. So if Medicare and Medicaid says, I'm only gonna pay $50 per 500 milliliters of contrast that you use, the hospital eats the rest of the cost.
well, temporarily until the patient pays it, right?
No, because when you're on Medicare and Medicaid, you can't charge the patient anymore.
Okay.
So the hospital eats it or has to pass on the cost to other patients by increasing the price they charge them. So the hospital can do that. Most hospitals will say, you know what, we're only gonna get paid for Omnipake, except for rare conditions, so we're gonna pay for Omnipake. And if you have renal failure or diabetes, acute MI or something like that, we're gonna give you VisiPake. So most hospitals will do that, they will subsidize.
But patient-centered when they're gonna be giving.
Yes,
everyone
most hospitals will do
just
patient-centered. However, you have to be aware of that. So some hospitals say rather than risk it, we're just gonna go all VisiPake and just eat the cost or pass it on to the insurance carriers because they can't do it to CMS patients. But VisiPake got sued because VisiPake said, hey, we're the best. And they compared themselves to Omnipake. And they said compared to Omnipake for peripheral vascular procedures, the patients had less complications, less risks, less complaints. I mean, they blew Omnipake out of the water for peripheral procedures and discomfort and patient preference. It wasn't even funny. It was a huge difference. So VisiPake said, hey, we should be used for every peripheral procedure. Except IsoView. IsoView sued Omnipake and said, guess what? You didn't go against us. We're not the same as Omnipake. It's the same. It's a different chemical mixture. And so IsoView did a very small study that said that they were almost as good. They were close to being as good as VisiPake. The patients still had a little bit more discomfort. It was a lot better than Omnipake, but it wasn't quite as good as VisiPake. So IsoView said you can use us for peripheral vascular procedures. The patients don't mind it so much, it's tolerable. And so some hospitals, because of the cost difference, will use IsoView on peripheral patients. And that's just because of a lawsuit that came out, and IsoView was able to protect and defend their market for peripherals. So when you're doing peripheral vascular procedures, you'll probably use either IsoView or VisiPay. Nothing else really should be used. Okay. Let me tell you what happens if you choose the wrong contrast agent. This happened to one of my former students. They were working in a lab. It was a very complicated case. The doctor says, okay, we need to reload the power injector. They're using the power injector. The contrast agent bottles, let me pull up a picture of contrast agent bottles
Yeah, read this.
and show, let me show you the problems with the contrast agent bottles. There's one here, I have one here that shows a bunch of bottles. Yeah, that's right. Wait just a second here. Yeah, that's right, this one. Okay, so let me show you here. Word of caution. This is what the high peak vial looks like. This is what, let's zoom in. The omni-peak labeling looks like. So high peak labeling, omni-peak labeling, VisiPay labeling. What do you notice about them?
The hookers and, yeah.
They're extremely similar. And they haven't changed. It's still how they are.
One bottle is really tall, one really small, right?
Yep. And also they all say peak at the end. High peak, VisiPay, omni-peak. They all say peak at the end, referring to the opacity or the opaqueness. So I had a student, they're setting up for the procedure, everything was going, it was a very difficult procedure, so he grabs a contrast agent, loads up the power injector, and they inject 20 cc's of
High peak.
high peak.
What about
The
asphalt?
student grabbed it and injected it?
He wasn't a student anymore. Yep. The student grabbed it and it was filled it was injected. The woman was screaming
Oh,
in pain.
Jesus.
Like they had to heavily sedate her because of the pain and discomfort that it caused. So, contrast agent selection and being observant of which contrast agent you are selecting is very, very important.
There's no reversal for
Nope.
any of that?
It has to work its way through.
Okay.
And since it was a completely blocked vessel, it just sat there.
Oh no.
So, when you say, well, what's the importance of this? It has significant importance on the patient. If the patient has congestive heart failure, I don't want to use a low osmolar contrast agent. I want to use an isoosmolar contrast agent because it's going to pull less fluid, less overwhelming the heart. I never want to use an ionic contrast agent. That's going to affect the heart rate. That's going to affect the patient's contractility. That can make congestive heart failure worse. So the real key is to make sure that you're choosing and selecting the right contrast agent for your patient, and that you verify this if there's a change with the physician, so the physician would know.
So did the physician order that, or did he just
He just
choose
grabbed
it?
it.
He just grabbed it.
Yep, we grabbed it. The physician
So
said
that's
we
like
need to-
on us, like
Yep.
that contrast.
You're responsible for the
You know
contrast.
what you need to get.
Yep.
So the doctor didn't order anything, he just got
But he
it.
just said, fill the contrast agent.
Oh, it's just like what contract, you know, it's like.
Well, no, we have to know the requirements. That's up to us.
No, the doctor have to say what contract, right?
No, he just said, because we've been using the same contrast for the entire procedure.
Oh,
He
okay.
said, fill it, grab the wrong one and fill it.
Oh, okay. I
That's
see.
on us.
Okay.
That's also like that situation where they grabbed, what was it, like an empty contrast container or whatever?
Well, they just didn't fill it up,
Injected air.
they just didn't fill it up, and they just injected air and filled the patient, because they thought it was filled.
Is a new contrast added to the power injector at every procedure, or is
Yep.
it just something
Every
that's?
well, generally, yes. Before you start any procedure, you should always look at which contrast is hanging.
Okay.
Maybe that should
That's
be
our
like part
responsibility,
of
because the
our.
doctor's not in there when we're setting up. That's on us.
Should
If
be
you
like a
only
little
know the high
private
contract,
timeout.
if you stop using that, so you still have it, you know.
Yeah, well, remember, we have it to fill up equipment.
Oh,
So that is some things. Now, the one thing we have not solved is contrast-induced nephropathy, but let's take a quick break here and come back, and we'll talk about contrast-induced nephropathy. Take a 5-minute break, and we'll talk about why do we have contrast-induced nephropathy. And I'm not going to be able to solve that. I'm not going to be able to tell you why, because we don't know. But there are the two main reasons. The first one is pretty clear, which is the iodine is absorbed into the nephron, and iodine at high enough levels is toxic to the nephron. Ergo, Latin for therefore, if I build up enough iodine in the nephron's going to be damaged. Okay. That's one of the possibilities. Now, the other possibility goes all the way back to something we talked about in physiology, in which hydrostatic pressure equals this thing called oncotic pressure. And what happens is when we get into a capillary, there's a lot of pressure in that capillary, and because of that pressure in that capillary, the water flows out. The cells stay behind. When the water flows out, the cells staying behind creates a density of molecules, which then pulls the water back in, establishing an equal flow. That's how a capillary works. Water goes out, water comes back in, and it moves on. Hydrostatic force, reverse oncotic force, and it moves on. And in the normal capillary, those are equal. Now we can change that by giving the patient, by releasing, I must have seen this, all right. I hate it when a word just, it's there, and all of a sudden you're about to say it, and your brain just goes, no more. We can reverse that by histamine. Histamine can make the capillary more permeable, and the cells follow it, and then you have to have your lymph nodes kick in. But on general, the hydrostatic pressure is equal to your oncotic pressure. Now, when we look at the nephron, something different happens when we talk about the nephron, however. With the nephron, we have this afferent arteriole that comes in here. And in the nephron, the hydrostatic pressure is higher than the oncotic pressure, just through its design. So if the hydrostatic pressure is higher than the oncotic pressure, a lot of fluid is going to be pushed out into the nephron, but what's going to happen to the amount of fluid that can be pulled back into the capillary?
Maybe less.
It's less. If the hydrostatic pressure is greater than the oncotic pressure, when they're equal, what goes out comes back in. But if hydrostatic pressure is higher than the oncotic pressure, we're going to force out a lot of fluid, and we're going to pull less back in. That's what happens in the glomerulus of the nephron? The excess water that's not pulled back into the capillaries go through the nephron. So there's more fluid pushed out by the afferent arteriole than is pulled back in, and that extra water goes through the nephron. Now, what happens here is as that fluid is going back in through the nephron, we get into this thing called the proximal convoluted tubule and the loop of Henle and the distal convoluted tubule. And what's happening in each of those spaces, we're not going to go step by step, but what's happening in each of those spaces is the kidney is absorbing, or the nephron is absorbing potassium and sodium. And as it's absorbing potassium and sodium, what follows potassium and sodium?
Water.
Water. So as I'm going through here, it's going to absorb more potassium. As it's absorbing more potassium, fluid will be pulled back in. Whatever fluid's not pulled back in the proximal convoluted tubule goes into the loop of Henle. In the loop of Henle, we're absorbing sodium. As sodium is being absorbed here, water is going to follow it on this side, and so we're absorbing more down here. Whatever water is not absorbed down here goes through the distal loop of distal convoluted tubule, and we have the last chance of pulling out electrolytes and fluids. Whatever electrolytes and fluids are not pulled out, guess what happens to them? By the time I get to the distal convoluted tubule, what happens to any water electrolytes that I have not absorbed?
Pee it out.
Pee it out. Okay, that's how this is supposed to work. When I give you contrast, the solutes in the blood is increased. You have more iodine electrolytes. Iodine is a salt. You have more iodine electrolytes than you normally would as you enter into the glomerulus. So for the glomerulus to work, my hydrostatic pressure has to be higher than my oncotic pressure. But because I have so much iodine in the blood, guess what happens to my oncotic pressure? It increases.
They're trying to just keep up that equal.
Well, by accident. Normally, I don't want that.
Yeah.
In the kidneys, I don't want that. I want the hydrostatic pressure to be higher than the
to
oncotic
release
pressure.
everything.
But when I have so much iodine in there because of the contrast I gave the patient, I have so much iodine on there that difference decreases. So instead of pushing out a lot of fluid and a lot of fluid staying out and less fluid being pulled back into the capillary, because of all the iodine from the contrast that's there, more fluid is pulled back and less goes into the glomerulus. And if less fluid goes to the glomerulus, what happens to my ability to get rid of fluid?
Decreases.
It decreases. And my kidneys start to fail.
That's scary.
So those are the two ways that we can kill off a nephron or damage a nephron. We can damage its function by changing the oncotic pressure. We damage its ability to function. Or the iodine can be toxic directly to the nephron, and we can damage the nephron physically. So we can damage the nephron functionality by changing the pressures that are occurring in that capillary, or we can damage the nephron directly because of the toxic effects of iodine.
So just by reducing the fluid to such a low amount, that can cause you a kidney failure?
Yeah, the nephron will just shut down. The nephron's like, nothing's moving, nothing's going through me. And the kidney will shut down. So, in both of those cases, the situation is dire. Okay. So, it's either a direct toxic effect, or a hemodynamic effect, and in reality, it is probably a mixture of the two. The key is, if you come to me already with kidney damage or kidney failure, what am I going to do?
Damage it more.
I'm going to make it worse. I will make it worse. Congratulations.
does that relate to, creatinine?
I'm just bringing that up. Just bring that up. Give me just a second. And it's not bringing it up. Can you just.
When you say a direct toxic effect, that you say about like the kidney didn't feel the acid, any toxin, any way byproduct?
Say that again?
The direct toxic effect? is
The
that-
direct toxicity effect?
Yeah.
It just damages the cells. It just damages the nephron directly.
Okay.
Okay, so this is in one of the readings that you have. I'm just going to put it up here. So how do we know somebody enters into contrast-induced nephropathy? Okay, so contrast-induced nephropathy doesn't happen right away. It's a slow period of increasing damage and frustration. We call it frustration of the kidney. What we mean by that is we're just not allowing the kidney to do its job. We're frustrating its job. Within 48 hours, what we do is we check their creatinine again. Now, if the serum creatinine increased 0.3 nanograms per deciliter from your starting point, even if it was normal, even if it's still normal, if your creatinine increases 0.3 nanograms per milliliter, you have contrast-induced nephropathy. We've damaged your kidneys a little bit. However, sometimes that's not enough. An increase in serum creatinine of 50% is also a sign of contrast-induced nephropathy. You might say, well, what's the big deal? Well, let's say you are at 0.5 nanograms per milliliter. And you go up to 0.75. Now you haven't gone up a full 3, okay? Because if I was at 0.5 nanograms per milliliter and I went up 3, I'd be at 0.8.
You're still in a normal range.
I'm still in normal range, but I still went up. It doesn't matter if you're normal or not. It is a sudden increase in 48 hours. But I went up to 0.75. Well, 0.75 is 50%. I would still be considered contrast-induced nephropathy. It's not severe. I'm not going to have to do anything with it because it's within normal range, but I have hurt your kidneys. I have done damage to your kidneys. And if your urine output of less than 0.5 milliliters per kilogram per hour for at least 6 hours on the 48th day, you are in contrast-induced nephropathy. That means I have slugged your kidneys and your kidneys are not happy. So then it says, well, what does that mean? And the answer is no. I don't have to do anything dramatically. In about 20 hours, normal functioning kidneys will clear the contrast. Okay, so within 20 hours of that, we can probably check it again. If it's cleared, then your kidneys are functioning. I did knock them. I did damage. I did, irritate your nephrons, but they've come down. Within that 20 hours, if it doesn't come down, if you're within the normal range, we'll watch it. If you're above the normal range, well, we have to start taking some more drastic measures, putting you on diuretics and things like that to try to clear out the contrast.
So this 20 hours is after that.
After 48 hours, yep. Once we determine that you are in contrast-induced nephropathy or you've suffered some effects, we check it for 20 hours. If it continues to go up, bad news. If you're above normal, bad news. We need to do something to bring it down. And the best way to bring it down is by increasing diuresis in most patients. After you have a heart cath, guess what they will tell the patient to do?
Drinking time.
Drink water, lots of water for the next 48 hours. We want them to pee out as much of that contrast as possible. That's how contrast is eliminated. You have to pee it out. Okay. So the next 48 hours, we just want them to drink lots and lots of contrast. If it's still high and it's above normal, we might give them a little bit of a diuretic for a short period of time to try to clear it out. If it's still high and it goes up, we need to talk to the nephrologist. The kidney doctor has to come in and determine what is going on and how badly they're doing the other kidneys.
So basically pee out on the iodine, right?
Yep, you're peeing it out. You're just forcing your kidneys to flush out the iodine, whether it wants to or not.
So it's just drinking the water or even the IV fluids are.
IV fluids will help, but you're going to be sent home within the next day. So we still want you to drink water for about 48 hours. As much water as you can, just pee as much as you can. And that will help avoid contrast-induced nephropathy. That will help get rid of, the longer the iodine sits in your system, the more the toxic effect it will have, the greater the hemodynamic effect it will have. So the faster we can get you to pee it out, the better.
How many hours after you had your procedure
48.
would you consider CIN is
48. If you're elevated with any of those three categories within 48 hours, you're in CIN. You have evidence of CIN.
But we wouldn't know that because we're sending them home.
They would be checked up at their family doctors.
Oh, okay.
Yeah, they'd be checked up. Especially if we use a little bit of contrast, we don't check them up. But if we use a lot of contrast, we'll follow them together 48 hours. They'll be told you'll need to have a blood draw, go to a lab or something for on this day to get it drawn.
So you only need one of three, right? Do you
You could have all three, but yeah, one of those three is enough to say that you have evidence of contrast-induced nephropathy. Now, if it returns to normal 20 hours later, you're back to normal. But if it continues to rise or it's elevated
Okay.
above normal
Okay.
20 hours after you drew the lab, then you are considered in contrast-induced nephropathy, and you have to go see a nephrologist. So the question comes up, how do we treat this ahead of time? So this chart right here just tells you who might be at risk for contrast-induced nephropathy. And it's really not a surprise. People with existing kidney disease, diabetics, they're everything. People of older age, because our kidneys don't function as well. People who are taking drugs that hurt the kidneys, that's obvious. You're already hurting your kidneys. People who already have poor kidney perfusion, such as dehydration. This is why we look at, is your patient dehydrated? And you'll hear me ask you, is this patient dehydrated? If they're dehydrated, I want them hydrated before I give them contrast. I want that up there. If they're in congestive heart failure, that means they're already not perfusing their kidneys well. That's going to be problematic. And then if you use a lot of contrast media, you're going to be at risk. So how do we treat it? And that's kind of what we're going to end on. So this is what we've tried. This is what we've tried. Sodium bicarbonate, N-acetylcysteine, statins, sorbic acid, adenosine, vasodilators, forced diuresis, giving you furosemide or Lasix, renal replacement therapy, that's putting you on short-term, that's what I'm looking for, dialysis, prostaglandin E1 administration. So if a patient is going to have a heart cath and they already have kidney disease, the question is, well, how do we treat them so we don't make it worse? And so we've tried all of these things. Down here it says, these are the ones that showed promise. NAC is the only one that showed some promise. Sodium bicarbonate was somewhat promising. Statins were somewhat promising, and NAC was somewhat promising. Everything else failed. Nothing else worked. And what we did is we did small studies, and everyone said, oh, this worked on the small study, and then we did a big study, and it failed. And then we tried the next thing, oh, this works on a small study, we did a big study, and it failed. So the things that showed promise are sodium bicarbonate, statins, and NAC. So let's talk about NAC. That's also called mucomist.
Mucomist.
Yes, it's called mucomist. It's a
Right up your nose.
It's supposed to be for that. Mucomist is a mist drug that is usually used for breaking up.
cystic fibrosis?
Yeah, cystic fibrosis, breaking up mucosal blockages, and they would inhale it. By accident, they also found that it protected people from Tylenol overdose. It protected kidney failure and Tylenol overdoses. But you have to drink it. Now, the reason I pause to say that is because mucomist smells like rotten eggs and tastes worse. And so to protect from Tylenol overdose, kidney failure, you would have to drink this. And the theory was, well, if that protects your kidneys from Tylenol overdose, could it protect your kidneys from contrast overdose? And most patients say, and there is a therapy protocol you're supposed to follow. You have to drink it, a couple times. Most of the time after drinking it once, you're like, never again. They'll say, put it in Sprite. You know what you get when you put mucomist in Sprite? Crappy tasting Sprite. It's just horrible. It is absolutely, it does not mask the flavor or smell at all. It's just now you're turned off from Sprite for the rest of your life. So mucomist was supposed to be an inhalation drug. It had some effect on the kidneys, but after we did the study, a large study, guess what we found? It didn't work. Statins, giving a statin right before contrast, a couple days before and a couple days following contrast agent. Statins stop inflammation. So they said give these patients statins, stop the inflammation caused by the iodine on the kidneys. Small study said it worked, large study said it didn't. Sodium bicarbonate, it's an IV drip. Start a sodium bicarbonate drip. Sodium bicarbonate decreases acidity. Contrast is acidic, and they thought maybe the acidity of the contrast damaged the nephrons. Small case study said it worked. Large case study showed it failed. The only treatment that has shown any signs of success is pre- and post-procedural hydration therapy. Does anyone know what that is? Drinking water and starting an IV on them. Flowing, getting their kidneys to pee. That's the only thing that has been shown to work effectively on patients. Some doctors will still try to use N-acetylcysteine or mucomist. I haven't seen sodium bicarb used forever. Some doctors still try to use statins because it's not going to hurt the patient, except they might throw up and they try to drink mucomist, but it's not going to hurt the patient. But the studies have shown that it doesn't really necessarily help the patient. The only thing that really is shown to help the patient, and you'll read it in this section here. The only thing that really helps the patient is hydration therapy. And you can actually click on each of these and it tells you how it worked. But as it says, meta-analysis seen and found compared with IV saline only, the following had reported statistically significant benefits on small studies, but on big studies, they failed. So, hydration therapy is still our best bet. So in other words, we don't have much in our toolbox to protect people from contrast. So the goal is, if they have kidney failure already, talk to the nephrologist if you can. If you have to do it, use as little contrast as possible.
There was something in the meeting that said something about pre-medication steroids.
Yeah, steroids, that would be the prostaglandins.
Okay.
And it doesn't really work. We tried. Again, stop the inflammation processes. It doesn't really work. Small studies say, hey, it's not going to hurt the patient, but it's not going to really benefit them according to the studies. You might see some doctors utilize it. Most of them just stick with hydration therapy. So that is contrast agent selection, what contrast agents are, and how we can try to protect the poor little kidneys from the slugfest that we're going to give to it. Any questions?
So like mucomist, statin, and bicarbonate only work for a certain patient, but not everyone, right?
We couldn't even find out why it worked. When you read the studies, they couldn't quite quantify who it worked on. Basically, it seemed to be random chance.
Yeah, that's why small group pacemaker.
Well, with random chances, it's not even that. It could just be.
Any patient.
It could be. Remember, causation does not, or correlation does not mean causation.
Yeah.
So it might be that these patients didn't have renal effect, but it might not have been because of the mucomist. It might have been because they didn't use enough contrast to cause it. So we don't know. It just didn't work. Didn't work as well as we thought it would. Okay, that is it. I will see you guys on Wednesday where we'll be downstairs, normal times again. Downstairs, scrubbing and playing with catheters and wires. Sound good?